the evaluation of patients with new onset of symptoms suggestive of CAD can be difficult for one reason because of the many testing options. Among the many papers from TCT published online simultaneously in JACC or JACC Interventions is this one on economic and quality of life outcomes of measuring fractional flow reserve with computer tomography, coronary angiography, and it is the platform study. And so I wanted to introduce you to Mark Hlatky, who is Professor of Health Research and Policy and a Professor of Medicine at Stanford University School of Medicine. First, platform. What do we need to know about this study?
Okay, this study, there's two parts. There was an earlier part that looked at the clinical outcomes, which showed that patients who were intended to go on to get an invasive angiogram, if instead you steered them to a CT angiogram with a fractional flow reserve, you cut down the number of people who went to cath, and especially the number who went down to cath with normal findings or non-obstructive coronary disease. And what we did in this part of the study was to look at what the economic consequences were of that and also the quality of life effects of that. And we took everybody over 90 days, 3 months, which is enough time to kind of figure out what you're doing, and counted up all the resources that were used, and we used Medicare costs, weights to figure out how much it would cost in the US, and compared them in the usual care group and in the FFR-CT guided group. And the long and the short of it is that the costs were about a third lower when you chose CTA with fractional flow reserve. And the reason was you avoided a lot of invasive procedures in those people. The tests came back and people said, well, we don't need to cath them, we don't need to do a PCI, so it saved a lot of money to do that. In
this day and age when money is so tight and people are trying to cut as much of it as they can from their budget, this is really good news. Yeah. I mean, I think it's good because, you know, you see the images and you can also say, well, I can see that there's something there, but it doesn't seem to be obstructing blood flow, which is both the anatomic and the functional information, I think, are complementary, and so that's a good package. Now, you also did some propensity score matching.
Right.
Did that change?
No, the propensity score matching, this is a non-randomized study. In propensity score matching, you're trying to simulate randomization. Right. And we did that. The effects were exactly the same, and the effects were so striking that it really, the tiny differences in terms of age and so on really didn't make a difference.
One of the things you say in the paper is, in light of the importance many cardiologists place upon images of coronary anatomy, the impact of functional data from FFCRT on clinical decision-making appears to be context-specific. What did you mean by that?
Well, what I meant was that in the invasive arm, when we see the anatomy, and then you say, oh, by the way, here's the functional data about that anatomy, it's very helpful. But compared with non-invasive testing, where you're just getting an exercise test, you can get when you get the coronary anatomy from a CTA, I think that still may invoke all of our reflexes as cardiologists, even though we have the FFR data.
That's great. In terms of where do you think this should be now, in terms of technology and its acceptance? Do you think we're so well established that this really should be a no-brainer to use fractional flow reserve when you can?
I think that it's really obvious in the invasive group that, we know that there's a problem where a lot of people go to invasive angiography and they have no obstructive disease. And if you can weed those people out beforehand with a non-invasive test that costs a lot less, that is good for them, and it's good for the good for the healthcare system to save the money. Where it's a little less clear to me after doing this study is compared to, say, doing a CTA with FFR compared to, say, doing a stress test of some kind. We didn't enroll quite as many patients, and the results were not as striking. We didn't save any money there. And so I think with only 100 patients in each group, though, that's too small to really be sure. We did see, intriguingly, though, that the quality of life was better in the people who got FFR-CT, and I wish I'd collected more data about why that was. My suspicion is that it's probably a reassurance value thing to say, well, your test looks normal, or we see some lesions there, but they don't seem to be blocking blood flow, so they're probably not causing your symptoms. That's very reassuring to patients, but I can't prove that.
So the bottom line takeaway message?
It's better to do a CT angiogram with FFRCT than a cath.
Very good. And there are a variety of papers that are from this meeting going on to either JACC or JACC interventions. Please check online. If you're seeing this video, it means the embargo has passed. So for Cardiol Source World News, I'm Executive Editor Rick McGuire.